Greetings and welcome to another meeting of Oral Pathology 360. This time we are talking about oral lichen planus, and as we know, it's a subject of much talk and much discussion because it's an oral potentially malignant disorder, and these are the disorders which are our early warning system. We find them and we are interested in them because they give us a hint of what could become malignant. But when the condition involved is seen in about 2% of the general population, there's another side. It is important, of course, on the part of being able to identify a malignancy early, but it has also got a very heavy cost on the patient if you're not right. Because, and if it is not really a potentially malignant disorder, because the psychological cost, the economical cost on the patient and the family can be a lot, especially a lesion that waxes and wanes, that keeps on coming back, and we have no cure for it. So every time it sort of turns up, it exacerbates, the patient is going to have another bout of a very scary time. Now, with that in mind, we have with us an expert and someone who is, I would say, almost of a rock star status amongst us from the way I have seen the reactions to the post that he is going to be with us. I bring to you Dr. Kamil Farah from Australia. Welcome.
Hello, thank
Oh,
you.
it's wonderful to have you here. And I know that everybody knows all the work that you have done and all the work that you're doing, and you have a very multifaceted professional life. And also, congratulations on your latest achievement of being in the top 2% researchers of the world.
Thank
But
you.
I'd like you, before we start, to tell about what you are really interested in right now and what you're working on right now.
Thank you very much, and thank you for the kind invitation. Really, my work at this stage is focused on two things, which I think hopefully at some stage in the future will converge. The first one is molecular genomics, and I'll highlight some of that data today in relation to lichen planus and lichenoid dysplasia and very similar conditions. And this is where we're using next gen sequencing and genomic approaches to understand oral diseases better. So, you said earlier, we still don't know what causes lichen planus and we still don't have a cure. And it's our obligation as researchers in this field to continue that work and to understand how to help our patients better. The second area of interest of mine has been for many, many years is optical imaging. And this is how we use technology to image soft tissues in a way similar to our medical colleagues in imaging hard tissues and other soft tissues such as CT and MR. So my particular interest is in optical soft tissue imaging and right now with confocal laser endomicroscopy. What I hope will happen over the years is that we can bring about understanding of molecular genomics to come up with new biomarkers for diseases, and then we will be able to couple them with fluorescent tags that we can basically then use optical imaging devices to look at soft tissues, to be able to diagnose, to be able to do surgery or undertake treatment, and also to monitor or survey our patients. So in a non-invasive way. That's basically what occupies most of my time, and that's why I'm very happy to share with the audience today. Thank you.
Thank you. Thank you for being here. And for everybody interested in connecting with Dr. Camille, you can do so on LinkedIn. His profile is there, and a link to his profile is also there on the event on the website. So I think we will go on with the lecture. I will, and then we will have, remember, audience, remember, you can put in your questions and comments in the chat. So let me bring in your first set of.
Think about.
1 second, there seemed to be a problem with the sound. I will just go back. Give me a second.
Right.
I will check it and then get back. Okay, I think you should be able to start now. Right.
Okay. Thank you very much again. So, thanks again for attending this presentation. Today, I'll talk about this controversial topic. As I alluded to earlier, some people believe very adamantly that lichen planus is a potentially malignant disorder, and some people have a complete opposing view. What I'd like to share with you today is data from the literature, new molecular data from our laboratory, and some published data from our laboratory around the molecular profile of lichen planus. And maybe that together that will shed some light on the topic. But if I can't convince you of whether lichen planus is potentially malignant or not, at least hopefully I can get the thought process moving forward to stimulate more research in this area. So before I start, I will be talking about various topics and issues, and these are my disclosures, specifically in relation to some optical imaging technology I'll present later in the presentation, and some of the genomic molecular data that I undertake with colleagues. Fuller list of my declarations, specifically in relation to the Contemporary Oral Medicine book, which I will use some references in this presentation. There's a whole myriad more data available in publications, which I will highlight. And before I forget, of course, I would like to thank all of the patients who have been with me for many, many years, allowing me to care for them, students, staff, collaborators, industry, and funding bodies who have supported my research and allowing me to move ahead with that. I'd like to just mention this particular symposium that was recently held at the IAOP meeting in Mexico, and this brought myself and Professor Gonzalez Moles for the first time together. We've never lectured together, and we had this mini symposium that we put together, putting arguments for and against the malignant potential of lichen planus and lichenoid lesions. And I would like to recognize Professor Gonzalez Moles for doing this with me and potentially having a great time in the process. And of course, taking on different opposing views in that presentation. Today, I'll share some of that presentation with you and, of course, highlight some additional aspects. I won't touch, of course, on Professor Gonzalez Moles' lecture. So we all have this problem with patients with lichen planus. I won't go into the specifics of lichen planus. Of course, we all understand what lichen planus is and how it behaves. But potentially in the context of malignant transformation, we have a clinical dilemma that we face clinically all the time. And that is, we can't predict if or when this mucosal lesion or condition will progress to cancer. Here's an example of a patient of mine articulated in our book, Contemporary Oral Medicine, who presented with lichen planus. And this is just one clinical presentation on the buccal mucosa over a period of 15 months, where the patient supposedly went on to develop malignancy in this location. The problem with this particular example that I give you and I will highlight in my presentation today is that the patient refused initial biopsy when he presented to me in the first instance. So, of course, although I had a clinical impression that the patient had lichen planus, the patient never provided consent to have an incisional biopsy to determine the presence or absence of dysplasia in this particular clinical setting, but also what the disease itself was. Was it truly lichen planus? Was there already dysplasia in this? Was it just dysplasia with an inflammatory infiltrate. And I'll touch on some of these diagnostic dilemmas in the presentation. And this is a common problem when encountered in the literature, that the stringency of the criteria used in some of the publications excludes, for example, lesions that have dysplasia on presentation. Also, some publications don't have histopathological confirmation of lichen planus for the patients they include in their publications. And of course, this continues to be a big problem for us in assessing the malignant potential of lichen planus. So, of course, there are a whole myriad of different clinical presentations of lichen planus. I won't get into those specifically, but to say that it has become generally acceptable that the presentation should be bilateral and symmetrical from a clinical standpoint, and that there should be histopathological confirmation of lichen planus. So the diagnosis is both a clinical and a histopathological diagnosis. That's important to note, specifically when we talk about studies looking at the malignant potential. So here we have three examples of what appear to be lichenoid pathologies of the oral tissues. One is a lichen planus case, one is a dysplastic case, and one is a so-called lichenoid dysplasia case. And so I'm going to start this presentation with an attempt to decipher this middle ground of lichenoid dysplasia. Is that entity lichen planus? Is that entity dysplasia? Is it truly a separate entity, or does that entity not exist? So in this particular instance, the image on the left is truly proven to be both on clinical and histopathological grounds to be lichen planus. The one on the right is a case of dysplasia, and the one in the middle was signed out as a case of lichenoid dysplasia, features of both dysplasia and a lichenoid infiltrate. And over many years, this particular condition has in itself been quite controversial. And you would most likely know of this fantastic paper by Drs. Krючков and Eisenberg, published in the 80s, which basically they articulated this new entity called lichenoid dysplasia as a very distinct histopathological entity. Now, I want to start with this particular paper because it sets the scene for much of what they discussed in their paper, but much of what we've been discussing since in relation to the malignant potential of lichen planus. And why did they come up with this designation of lichenoid dysplasia? And if you go back and read this paper, it's a very nice paper. Basically, it was an attempt to explain the malignant potential of lichen planus, and in that particular instance in the mid-80s, looking at some of the reasoning behind the additional claims of malignant transformation of lichen planus. It was also an attempt to understand or to designate what was occurring in the literature, and potentially explaining some of that with a different classification system. And we use classification systems for a whole myriad of reasons. Obviously, one of them may be to allow us to report and make our diagnoses, but also to study the natural progression of disease and the natural history of disease. So obviously the authors felt that lichen planus wasn't truly a malignant or pre-malignant disorder, and there must have been some other reasoning for why there was an additional uptick in the reported cases of malignant transformation of lichen planus. And very importantly, the primary objective is to avoid rendering a diagnosis of lichen planus unless there was specific strict criteria that were met and satisfied. And that was one of the reasons why they came up with this entity called lichenoid dysplasia. Now, as you'll see when we decipher this paper in a little bit more detail and look at some molecular data from our lab, the intention was quite noble, but the criteria used to actually come up with this term lichenoid dysplasia, I don't think satisfied the initial objective. So, in looking at these subdivisions of lichenoid lesions that Khrushchev and colleague came up with, we have the designation of lichen planus, and I won't go into too much of the histopathological criteria used. Some we still use, some we've basically discarded along the way. But importantly, as we move towards these other entities, in particular, this entity they termed as lichenoid dysplasia, they stated that the crucial determinant that allows separation of lichenoid dysplasia, as they defined it, from lichen planus, again, as it was defined at the time, was the additive presence in the former, i.e., this entity called lichenoid dysplasia, of dysplastic features. So basically, what they were trying to say is there is this separate entity other than lichen planus known as lichenoid dysplasia, and this particular condition already contains dysplasia. So here's an attempt at basically creating this new entity, but doesn't in itself resolve the issue around whether lichen planus truly transforms through the dysplastic stage into malignancy. So the crucial determinant that allows the separation was the presence in lichenoid dysplasia of dysplastic features. Now, as we'll come to understand in more recent times, there's an argument to say that dysplasia should be an exclusion criteria for a proper diagnosis of lichen planus. So, in itself, of course, if we have lichenoid features and dysplastic features occurring concurrently in a lesion, Khrushchev said, well, we should designate that as a separate lesion called lichenoid dysplasia. Now, if you think about the logic is that lichenoid dysplasia would transform to malignancy and not lichen planus would transform to malignancy by creating this new entity. So at the same time, we continue to look with skepticism at reports of malignant transformation of lichen planus, they said. So they're basically trying to move away from this understanding that lichen planus transforms, but instead this new entity that they created transforms. Now, as I said, this is fraught with danger if you start to look at more of the recent literature. And you look at the histopathological criteria and features that they designated for lichenoid dysplasia. If we forward fast track to some other classification systems, and we start to look at how they fit into designations of lichen planus, and the changing and evolving features of dysplasia. From the most recent WHO book, you will note there are architectural features of dysplasia and cytological features of dysplasia. There are 16 architectural features and 12 cytological features. And of course, we may be able to use various combinations of these cytological and architectural features in rendering a diagnosis of dysplasia. However, many of these features may be seen in lichen planus or may be, importantly, misinterpreted in the presence of lichenoid inflammation or lichen lesions. Now, for this, I draw your attention to synoptic reporting. And one of the things that I do in my reporting of dysplastic cases, and I find very useful for lichen planus cases, is to literally go through each of the architectural features and the cytological features when reporting cases of dysplasia or lichen planus, and to designate whether they are present or absent, and to use that as a purposeful summary of those features in rendering a diagnosis. Of course, We must always be looking at the inflammatory infiltrate, and I'll make more commentary around that. But this is one attempt to try to resolve this issue around whether lichen planus truly is potentially malignant or not. And it comes down to accurate reporting and accurate diagnoses. Now, you would also be aware of other papers that have looked at the clinical pathological correlation features in lichen planus and other classification systems that have come out of some of this work in an effort to either explain or limit the malignant potential of oral lichen planus and lichenoid lesions. So from this modified set of diagnostic criteria for lichen planus and lichenoid lesions, we start to understand some of the earlier comments that I've made around the lesions are symmetrical and bilateral in the clinical context. Whether they're erosive or reticular or atrophic is an additional item to be resolved. But importantly, the histopathological features exclude the presence of epithelial dysplasia. So if we believe that lichen planus is a separate entity requiring a set of clinical and histopathological criteria, and one of those is the absence of dysplasia, by nature, by definition, then one, lichenoid dysplasia cannot exist. And two, any paper that basically does not exclude dysplasia in reporting malignant transformation should not be included. So obviously, not everyone agrees with these criteria. So I'm going to highlight to you some reports that look at the overall malignant transformation rate of lichen planus and lichenoid pathology to highlight the discrepancies and to explain the role of presence of dysplasia in these papers. So here's one systematic review that showcases the overall transformation rate of lichen planus being 1.09, and that of lichenoid lesions or non-lichen planus cases, if you will, to be higher at 3.2%. If we go to other papers that have basically tried to do the same, we have a pooled proportion of malignant transformation of lichen planus at 1.1% and of lichenoid pathology at 2.5%. So again, showcasing individual or isolated lichenoid lesions always having a slightly higher malignant transformation rate than lichen planus. Other papers showcase different features. So here we have a rate of 1.37% for lichen planus and 2.43% for lichenoid lesions in another review and another meta-analysis. And here we have another one at 1.14% for lichen planus and 1.88% for lichenoid lesions. Now, it's very important to understand what is included partly in the studies that are reported in these systematic reviews, but also what is included in the groupings of lichen planus and how they define lichen planus. And importantly, if we're looking at the criteria for lichen planus, whether that truly included or excluded dysplasia. And you will see from this particular paper that the malignant transformation was recorded in this dysplastic lichen planus group of 6.22%. So in this particular paper, they did not exclude the presence of dysplasia when they assigned the lichen planus group. So here we have cases of lichen planus demonstrating dysplastic epithelium or features of dysplasia. And of course, the malignant transformation rate in this particular subgroup was very high at 6.2%. That is higher than most other cases of reported transformation in the literature. Again, Another assessment showed that the pooled proportion expressed as percentage of malignant transformation of lichen planus with this methodology in this particular systematic review was 2.28%, still higher than some of the other publications where that was typically sitting around 1 to 1.5%. Now, if you use very strict criteria for your systematic review and meta-analyses in relation to the papers used, but also strict criteria for what is designated as a lichen case, you'll find, as we found in our systematic review and meta-analysis, that in actual fact, the malignant transformation rate is actually quite low and is much lower than reported in the general literature using these very strict criteria. So we found the malignant transformation rate of lichen planus to be 0.44%, which is much lower than other studies reported. And in this particular paper, we use very strict criteria. And that was commented on by others, looking at why our rates were lower than some of the other reported papers. Now, for us, we used the American Academy of Oral Maxillofacial Pathology criteria. And in this particular work, the designation of lichen planus basically excludes the presence of dysplastic features to render that diagnosis. So these are the criteria that basically we use, and these are the criteria that we think should be used in order to avoid further confusion around the malignant transformation potential of this condition. So, of course, if you're already including dysplastic features in your lichen planus sign out, and then, of course, that particular lesion went on to transform, potentially what is transforming is the dysplastic component and not necessarily the lichenoid component. So we believe that a true diagnosis of lichen planus should not include any evidence of dysplasia as articulated in the WHO book, whether that be cytological features or architectural features. So here, the absence of epithelial dysplasia and the absence of verrucous epithelial architectural changes are what we believe should be followed, and the modified WHO criteria published in the early 2000s absolutely indicated that there should be absence of epithelial dysplasia to render the diagnosis of oral lichen planus. And if we basically take care of these cytological and architectural features and exclude them from a diagnosis of lichen planus, potentially that may render the transformation rate to be much lower than reported in the literature. Now, this is still a significant problem. It's a significant problem because sometimes these features are not easily determined on histopathological assessment. We know that when we have a florid lichenoid inflammatory infiltrate, that there can be reactive epithelial features noted, reporting these with clarity for the absence of dysplasia is quite difficult. Now, also in the recent past, with the designation of lichen planus or lichenoid lesions as potentially malignant, there hasn't been agreement on excluding dysplasia. So we've made the case that dysplasia should be excluded, but we've also shown that using the criteria of the American Academy of Oral Maxillofacial Pathology for lichen planus, it is reasonably difficult still to get agreement amongst pathologists, specifically oral pathologists in this instance, as we've articulated in this particular paper. So when we're looking at intra-observer agreement, which was reasonably good, there was still disagreement on features of dysplasia, but also features of lichen planus using said American Academy criteria. So we recognize that there's still quite a bit of work that is required, and you can see here the presence of epithelial dysplasia. There was only fair to good agreement between the observers in our particular publication. Now, others have made similar commentary, similar to ours. Here's a paper talking about the natural history of oral mucosal lesions with both lichenoid and epithelial dysplastic features. And again, the argument here that is that epithelial dysplasia should actually be removed or rejected from a diagnosis of oral lichen planus. The problem with the current classification, however, is that if you look at the work published by the WHO Collaborating Center for Oral Cancer, oral lichen planus and the criteria used there, dysplasia was not an exclusion criteria utilized for making this designation. And I believe this is actually adding to the ongoing dilemma around whether lichen planus or indeed lichenoid lesions, which is a completely different discussion, truly have malignant transformation potential or truly have a very high malignant transformation potential. So again, going back and looking at the clinical and histopathological criteria that are placed in these classification systems, it's important to note that in this particular instance, the presence of dysplasia was not an exclusion criteria. And I believe fundamentally that's incorrect. So the literature tells us that there are a whole heap of different viewpoints. Classification systems currently don't agree, whether you're looking at the American Academy classification, whether you're looking at the WHO Collaborating Centers classification. We wanted to understand this in a little bit more detail. So one of the bits of work that we did in our group was taking this entity called oral lichenoid dysplasia, as I've highlighted earlier, and looking at the malignant transformation rate of that entity versus something proven to be oral lichen planus. Now you can see here that oral lichen planus and lichenoid lesions displayed a low risk of malignant transformation at 0.49%, and for lichen planus in this particular study at 0% for lichenoid lesions. But in contrast, patients with this designated entity of lichenoid dysplasia showed a very high risk of malignant transformation, 6.8%. You may recall at the previous systematic review that I highlighted by Professor Gonzalez Mols and colleagues showed that that group of lichen planus, where they did not exclude dysplasia as one of the criteria, had a very similar malignant transformation rate of 6.8 something. So we really believe that it's this entity that's basically stuck in the middle of the continuum, the so-called continuum between true lichen planus and true epithelial dysplasia, that possibly accounts for the high malignant transformation potential of so-called lichen planus. So I want to unpack this a little bit more in a little bit more detail. We looked at the population base and the clinical base in our clinic, but we wanted to understand this in a little bit more detail from a molecular genomics perspective. So we know that oral cavity carcinoma can form in patients with lichen planus. We also know that there are lichenoid features present in dysplastic cases and cases of squamous cell carcinoma. So many of you would have seen lichenoid inflammatory infiltrate as a feature of these pathologies. There are lichenoid characteristics in other premalignant lesions such as verrucous hyperplasia and verrucous carcinoma. Of course, all of this makes it more difficult to discern what is truly dysplastic, what is truly lichenoid, and what is a combination of both. Now, to complicate the picture, I don't want to digress into proliferative verrucous leukoplakia, but there is also discussion of lichenoid infiltrate and lichenoid morphology as an early feature of PVL. We know that that is the case, and I'll try to highlight some molecular and immune-based data to showcase that. But we should not complicate the picture even further with lichenoid features in PVL. So let's move on to try to unpack some of this from a molecular point of view. Here we have loss of heterozygosity studies that look at lichen planus, and you see that loss of heterozygosity was present in 6% of lichen planus cases, but in 40% of mild dysplasia cases, 46% of moderate dysplasia cases, or 81% of severe dysplasia cases. So, of course, even in the context of some of the molecular changes, the changes that are occurring in lichen planus are on the far left and the minimal end in relation to truly dysplastic pathology. Also, in this particular paper, the authors highlight that dysplasia with or without a lichenoid mucositis or a lichenoid infiltrate had a similar cancer risk. And that again starts to bring into question the whole issue around the diagnosis of lichenoid dysplasia, or in this particular instance, the designation of lichenoid mucositis with dysplasia. So again, are we talking about the dysplastic component, or is it really the lichenoid component that is driving the malignant potential? And this is one of the things that we'd really like to understand more fully from a molecular genomics point of view. So in the next set of slides, I'd like to discuss precision diagnosis approaches to lichen planus, to dysplasia, and by using this middle ground of lichenoid dysplasia, and to debunk the idea that lichenoid dysplasia is truly a distinct entity. So just before I move into this particular area, I just want to bring to attention the way that we go about making clinical diagnoses, making histopathological diagnoses. And as clinicians, we look at the clinical changes. Now in the context of lichen planus, we've said that we need both clinical changes and cellular changes. So we're looking at the histopathological changes in that regards also. But what we see clinically has occurred as a consequence of very early events, either as genetic defects or more likely as molecular changes, which are not observed by the naked eye in clinical assessment, and most definitely not observed by histopathological assessment using microscopy. So there is a disparity between how these precancerous conditions are being observed clinically or histopathologically and the diagnoses made in comparison to basically how they originate and how we come to understand them and their etiology and pathogenesis from a molecular standpoint. So with the next set of slides, if we could move on to the next set of slides, I'll articulate now some molecular evidence to showcase that using lichenoid dysplasia as an example. Go back. Right. So let's move on to this particular paper that makes some attempt to decipher the molecular landscape of lichenoid dysplasia, and hopefully I can convince you that one, this entity does not exist in its own right, and two, this entity may be the cause of quite a bit of the work and the misunderstanding around the malignant potential of lichen planus. So in this particular paper, we've basically looked at three groups of disease. We've looked at true lichen planus based on clinical and histopathological criteria, a group of epithelial dysplasia, and this middle ground designated by multiple pathologists as lichenoid dysplasia. So obviously displaying features of both as per the original definition of Khrushchev. Now, one of the things we obviously wanted to do here was to decipher the molecular pattern, but we also described the clinical appearance and the designation of each of these lesions in comparison to the general literature. When you undertake unsupervised clustering of all of the lesions put together, and you can see that the patients with lichen planus are designated in green, the patients with dysplasia are designated in blue, and the patients with lichenoid dysplasia are designated in orange. There is no definitive separation between these lesions based on unsupervised clustering. There is a grouping, however, of lesions with the bar occurring on the far right, where both lichen planus and lichenoid dysplasia patients were clustered together in one arm, which is on the far right, and they demonstrated a particular signature shown by the black bar on the right-hand side. Now, of course, we can unpack this information a little bit more by undertaking further clustering, and this is supervised now, where you can see the groupings starting on the far left. We have the dysplastic group separating out from the lichen planus group. In the middle, we have the lichenoid dysplasia group segregated out from the dysplastic group. And on the far right, we have the lichenoid dysplasia group separated out from the lichen planus group. Now, one thing I'd like to draw to your attention on the far right is that there are fewer genes that separate lichen planus from lichenoid dysplasia. And that's a very important observation, because obviously if both of these entities share a molecular profile, there would be fewer and fewer genes that would separate them. And that's one of the first observations that we're noting in this particular graph. Now, another observation is looking at the molecular transcriptomic profile and seeing the number of significantly differentially expressed genes between the groups. So in this particular plot, you will see that the red boxes would designate significant changes between the two groupings. And of course, the more red boxes we see in these comparisons, the more significantly different these entities are. So when we're comparing lichenoid dysplasia to dysplasia or lichen planus to dysplasia in the graphs A and B, you can see that there is a significant amount of differentially expressed genes. However, when we look at plot C and we're looking at comparison between lichenoid dysplasia and lichen planus, here there are fewer significantly differentially expressed genes occurring between these two comparisons. Again, showcasing some similar features in the previous plot. So a lot of these genes are common to both lichen planus and lichenoid dysplasia. Importantly, there are differentially expressed genes between lichenoid dysplasia and dysplasia itself, as highlighted in plot A. Now, we can go on to do more sophisticated network mapping, which I won't go into too much at this stage, but just to highlight that that was done. And importantly, what I would like to designate is the separation that we can undertake by looking at these gene lists and trying to come up with biomarker sets that will separate one of these clinical or histopathological entities from another based solely on a molecular profile. And you can see very clear separation between the lichenoid dysplasia group, the lichen planus group, and the purely dysplastic group. Now, from this work, we can then come up with a set of genes or a set of biomarkers that may be used for either prognostic or diagnostic purposes. Obviously, they still need validation, and a lot more work is still required to test them on other cohorts, but this is the starting point for this work. But importantly, for this particular exercise, it's showcasing objective molecular evidence for the similarity of lichenoid dysplasia and lichen planus. And if you plot these under rock plots, you'll see that the measures of sensitivity and specificity are quite high. Now, when you also look at the inflammatory infiltrate between these groups, you'll see that there are also similarities between the lichen planus group at the far top aspect of this plot and the lichenoid dysplasia group at the far bottom of this plot. There are similarities in the infiltrate itself, whether that be CD4, CD8 T cells, and there are similarities in relation to the macrophage profile. So another way of looking at that is by comparing the lichenoid dysplasia, he designated in orange, compared to lichen planus designated in green. So there are similarities in the macrophage profile, in the CD8 profile, in the Treg profile. Again, further evidence that inflammatory infiltrate is similar between the two designated groups. So the histological evidence of lichenoid features in dysplasia and squamous cell carcinoma biopsies are quite common, as we've said earlier. We know that there are transcriptomic differences between dysplasia and lichen planus and similarities between lichenoid dysplasia and lichen planus. And based on these objective molecular features, we do not believe that lichenoid dysplasia exists as a separate entity. Now, if you go back and make comparisons to the previous paper by Khrushchev, they were designating this new entity in an attempt to explain the high malignant transformation rate of lichen planus. What we're saying is, one, that entity does not exist. In actual fact, what may be occurring is that the lichen planus may be inducing what is interpreted as a dysplastic change or a reactive atypical epithelial change. And indeed, we must also remember that dual pathology may actually exist. So the patient may present with both lichen planus and with epithelial dysplasia on that biopsy. And that does not necessarily indicate that lichen planus has a very high malignant transformation rate. The similarity of the immune phenotypic profiling between the two also adds further evidence to that. So the conclusion from our paper is that lichenoid dysplasia is not a distinct histopathological entity. That paper and the previous very high rates of malignant transformation of 6.8% for lichenoid dysplasia, we believe explain why in the literature lichen planus is still thought to be a potentially malignant disorder. And until we basically get clarity on the features that we'll use for designating lichen planus, we'll continue to run into these problems when we do systematic reviews and meta-analysis. Of course, we should not complicate the picture any further with looking at lichenoid features in PVL. And in many instances, those early cases of PVL can be misdiagnosed as lichen planus. And that's another complicating factor for us in clinical practice, but also in research. We've attempted to explain some of these in another paper of ours looking at the gene expression profile of proliferative verrucous leukoplakia. And I just want to highlight one part of this particular paper here, looking at, again, the differences in the transcriptomic profile, specifically when there was a lichenoid infiltrate. So again, if you're looking at the plots E and F, when we're comparing PVL with lichen planus, there's significant difference in the molecular profile, but also looking at PVL dysplasia versus lichenoid dysplasia, there is a significant difference in the molecular profile. Now, we wanted to unpack this a little bit further, and we did further network analysis, which, again, I won't go into too much here. But we also, very importantly, looked at the immune profile. And again, if you start to look at the lichen planus group and decipher that specifically from PVL, but also on the right-hand side in the dysplastic group, you'll see that there is a significant, very strong, very distinct immune profile seen in lichen planus that is not necessarily seen in either PVL or in true dysplasia. There is obviously an opportunity here to use that immune profile to help designate true lichen planus cases and to distinguish that from dysplastic pathology, whether that be in PVL or other. This is a paper from our group using machine learning to also identify lichen planus with a little bit more certainty. Of course, that requires assessment of the inflammatory infiltrate and then designation of that inflammatory infiltrate into an algorithm that can be used to automatically identify the infiltrate in slides, and then, of course, give some more clarity for the diagnosis of lichen planus in an attempt to move us away from further complicating the picture by misrepresenting the inflammatory infiltrate. You can see there are similarities between the lichenoid lesion and the so-called lichenoid dysplasia group, but that is distinct from true lichen planus. And whether based on true histopathological criteria or based on AI algorithms, we can separate the two based on the inflammatory infiltrate. And I can't go into too much of the detail, but other ways that we might be able to do this is to use other diagnostic markers, such as immunohistochemistry, for a whole range of immune expression profiles. This is, again, just one attempt at doing that from our group using cell blocks and liquid cytology. Of course, this can be done on straight biopsy specimens, and the work continues trying to understand what markers are upregulated and what markers are downregulated that can truly help us distinguish lichen planus from dysplasia with lichenoid pathology. We still believe that diagnosing lichen planus using the American Academy criteria should be the first point of call in us trying to resolve some of these issues in the literature. And we do believe that dysplasia should be excluded from these assessments. Now, if this is not done, there's a whole myriad of opportunities for misdiagnosis or misinterpretation when you're looking at cases of lichen planus. So here are a couple of scenarios. The first one is based on histopathology. We have a true lichenoid lesion or a true case of lichen planus. We have no dysplasia on histopathology, but we have a very strong inflammatory infiltrate. The pathologist overestimates the epithelial changes as a reaction to the inflammatory infiltrate, underestimates the inflammatory changes themselves, misinterprets the epithelial changes as dysplastic and not reactive, overcalls the dysplasia, and of course gives an incorrect diagnosis. We use this in future research, and we basically call out a very high rate of malignant transformation for lichen planus. Here we have a second scenario, again based on histopathology. There is no true lichen planus or lichenoid pathology. Actually, there's another condition. Maybe it's a mild reactive lichenoid infiltrate. There are some true dysplastic epithelial features present, but these are early or subtle. The epithelial features are underestimated. The infiltrate is overestimated. The pathologist calls out the lesion as a lichen planus or a lichenoid lesion, misses the dysplastic features, and the patient goes on to transform. This overcalls, of course, the importance of the inflammatory infiltrate, leading to future incorrect call of a lesion as OLP with malignant transformation. And these opportunities for misinterpretation and misdiagnosis are occurring all the time. Scenario number 3, we have true dysplasia, fully apparent, eliciting a very strong reactive inflammatory infiltrate. The infiltrate is overestimated. The lesion is called oral lichenoid dysplasia. The patient goes on to transform. It's interpreted as OLP that has gone on to malignant transformation, when actually it was dysplasia going on to malignant transformation. And the last scenario, based on clinical plus or minus histopathology. So on clinical assessment, the lesion looks lichenoid, may even have a plaque-like designation, such as PVL or a so-called plaque-like lichen planus. We know that lichenoid features can be present in early PVL cases. We know that plaque-type features can be seen in multifocal leukoplakia. No incisional biopsy is undertaken, similar to the case I highlighted earlier from my clinic. The patient transformed. The clinician calls that a case of lichen planus transforming to malignancy. Incisional biopsy is taken, and due to the presence of a lichenoid infiltrate that's seen in PVL but no other OLP features, it was incorrectly called lichen planus. Again, this overcalls the clinical features, the histopathology, the inflammatory infiltrate, but the malignant transformation is due to the presence of leukoplakia or PVL and not to lichen planus. Of course, we might continue to have a whole myriad of scenarios where we might still make misrepresentations or misdiagnoses. So We're trying to attempt to look at this also from a molecular standpoint, and I want to highlight the next 10 slides are unpublished data from our group looking at a group of patients diagnosed with lichen planus that tracked over time have gone on to develop either dysplasia or malignancy in those lesions, and we've designated that particular cohort as lichen planus MT, malignant transformation, in comparison to a control group of lichen planus samples, which again been tracked over time. They have not transformed, and they are the controls or the non-MT group. So you can see here that we've got about 10 or so patients in each group. The MT group has multiple biopsies taken over time, an initial biopsy and maybe a subsequent biopsy or two that's demonstrated dysplasia or carcinoma developing over that period of time. Now, again, this is unpublished data, but what I want to showcase is the ability of us using either whole exome profiling or transcriptomic profiling to start to understand the pathways that may be involved in these two cohorts a little bit more. So here is a whole exome sequencing summary plot of the whole data set, so all of the cases put together. And what we see here is there's significant missense mutation in the data set, a significant SNP variance in the data set, and a significant number of mutated genes on the lower right-hand side. When we start to look at designations in each of these cohorts, so we make a comparison between the cohort that so-called transformed versus the control cohort, we don't see a lot of differences. We see similar missense mutations, we see similar SNP variants, and also when we're looking at the variance per sample, we see a similarity there. And we see some similar top 10 mutated genes between the two groups. So we're not seeing significant differences between the two cohorts, whether that patient with lichen planus mutated versus the cohort that did not mutate. When we look at these whole exome summaries for the samples that displayed dysplasia or squamous cell carcinoma, and those that showcased lichen planus alone, again, we're seeing some similarities between the two cohorts. Now, when we start to look at comparisons of the top 10 most significantly mutated genes between the cohort that transformed versus the control, we see that there are a list of genes that were significantly mutated between the two. And some of these have been seen in other cases of progression of pre-malignant pathology to malignancy in other conditions. And there are some of these genes already known, and their purpose is already known in the context of transformation, and some of them are actually unique. But what you do see that there's a significant difference in the percentage of those cases in the malignant transformation cohort on the right versus the control cohort on the left. So, of course, this requires further additional study and analysis. When we look at the mutations in the first OLP biopsy samples from patients who developed malignancy compared to the control OLP samples, there was no significant difference in the differentially expressed genes between these two cohorts. And again, this requires further confirmation and assessment. This is excluding subsequent biopsies that have demonstrated dysplasia or malignancy. So on first biopsy, strict lichen planus between the two cohorts. So what this really tells us is that potentially there are no genes that may be able to tell us on first biopsy whether the patient has the potential to move on or to move into transformation in due course. And maybe those features that occur later in the process are related to dysplasia forming in that tissue as a separate disease process and not as part of a predictive panel of genes seen in lichen planus in its pure form. When we look at oncogenic pathways involved in both cohorts that went on to transform versus the control lichen planus group, we don't see any significant differences, again, in the pathways that are involved, but also the fraction of samples affected, whether that's in PI3K, Notch, TP53, or other pathways, which is quite important when we're trying to understand global changes in the gene pool and mutational differences between the two groups. When we look at mutations affecting known cancer driver genes, there are some similarities between the MT group and the control group, and really no significant differences again seen between the two, really raising further doubt as to the fact that lichen planus in its own right, with exclusion of dysplasia, is truly potentially malignant. And again, when we look at mutations affecting known cancer driver genes in the dysplastic and SEC group, proven on histopathology versus all of the lichen planus samples, once again, there's no significant differences between the two cohorts. So this, of course, requires further assessment. Some of the genes are well known to us in the context of malignancy, for example, FAT1. Some genes have been demonstrated in other potential malignant disorders, such as PVL. So KMT2D has been shown in PVL, and of course, some others require further assessment. And this is, once again, I'll highlight that it's unpublished data and requires further assessment. When we start to look at the differential expression between these two cohorts using these similar plots, when again the greater majority of the red or blue colored boxes designates further or significant differences between the two cohorts, you'll see that there are some differentially expressed genes between the lichen planus group with malignant transformation and that of the control, but there aren't that many. So there are very few of these genes that are present. And of course, we still need to understand their role further. When we look at differences between patients with lichen planus from patients who develop malignancy and the control samples, and you can see that the numbers of patients here samples here are far fewer. We have only 4 in the MT group versus 9 in the control group. We see very few differences. Of course, this may be a factor of the number of cases in our cohort, but trying to find cases where they've moved on to transformation is quite difficult. And when we look at SEC confirmed cases versus all of the lichen planus cases, once again, there are only very few genes that separate the two, and many are known in the context of malignancy, such as the MMP group, which we don't necessarily see in lichen planus. Now, one last couple of slides here to help make comparisons. When we look at dysplasia used in the context of designating leukoplakic cases and the dysplasia seen in this particular cohort of lichen planus transforming through to malignancy. And when we compare the dysplastic profile here between the two cohorts, we see no differences in the differentially expressed gene profile. What that really suggests to us is that here the similarities between the two groups is quite profound. And of course, what we're looking at is the role of the dysplastic epithelium, whether that be in the lichen planus case or whether that be in the leukoplakia case. The differences are not down to the presence of an inflammatory infiltrate. What is potentially causing or leading to the transformation is most likely contained within the dysplastic compartment and not within the inflammatory compartment of lichen planus in its own right. So, from this very early objective molecular analysis, we see no convincing evidence of the premalignant potential of lichen planus, and most definitely not as convincing or consistent or conclusive as that characterizing dysplasia. And of course, this is very early data, needs to be verified and further analysis undertaken. At this stage, as I alluded to, it's unpublished, but we will publish this in due course. So, of course, there are still significant problems that we face. There is a discrepancy around the standardized reporting of the data in the literature. We need to overcome that. Similarity of clinical and histopathological features of other conditions that may resemble lichen planus, we need to overcome that. We need to overcome the issue of inclusion of epithelial dysplasia in the diagnostic criteria used for inclusion in either original studies or systematic reviews and meta-analyses. And until that is done, we will continue to have discrepancies in the reported data. This altogether puts significant doubt, in my opinion, on the data used to report the malignant potential of lichen planus. I hope that I've convinced you a little bit, or maybe at least raised some doubt in your mind regarding the significant number of discrepancies, whether they be in original data, they be in meta-analyses, systematic reviews, or classification systems that basically continue to cause confusion and to continue to give the false impression that lichen planus is very highly malignant, very highly transformative in the context of its malignant potential. There are, of course, a whole myriad of ways that we could use to assess our patients and their lesions that are non-invasive. And this is where the interest in optical imaging comes in. There's a whole myriad of different technologies available, whether you use fluorescence imaging, narrowband imaging, confocal imaging, and various pros and cons for each of these optical imaging technologies. Fluorescence imaging is really good to give you a broad brushstroke approach to the presence of an inflammatory infiltrate and the presence of dysplasia using diascopic fluorescence as one of the tools, and looking at that with complete diascopic fluorescence indicating the presence of lichen planus versus partial diascopic fluorescence indicating the presence of dysplasia on histopathology. We've looked at the various molecular profiles associated with the presence of diascopic fluorescence or otherwise indicating the presence of lichen planus. And I won't allude to that further, but on molecular grounds, we've been able to separate these pathologies further, indicating to us that true lichen planus is not necessarily a potentially malignant disorder. Narrowband imaging has also been used to designate the potential for monitoring lichen planus cases. If you've used narrowband imaging, you'll know there are various subtypes of the IPCLs that can be used to monitor dysplasia and malignancy. We've also been able to use narrowband imaging in this publication to monitor the transformation of lichen planus cases using narrowband features, but also very importantly to diagnose cases with either dysplasia or malignancy on initial presentation using IPCL patterns on narrowband imaging. So narrowband can be used in the diagnostic sense, but also in monitoring for malignant potential. And lastly, more recently, we've moved to use optical microscopy using confocal laser endomicroscopy to give us a more detailed cellular and cytological approach to look at these pathologies instead of the macroscopic or mesoscopic approach used in, say, fluorescence, autofluorescence with Velscope or with narrowband. So in this particular paper, we've used this optical endomicroscope to look at cellular features of the oral tissues based on morphological grounds and cytological features of the different anatomies, but also looking at the different pathologies, whether they'd be lichenoid, and you can see that in image C, whether that be dysplastic in image D, or truly in malignancy. And you can see very clear cytological differences on endomicroscopy in real time. And this, of course, is the whole approach of real-time optical biopsy, where you don't need to take then a physical biopsy for diagnosis, but you can also use this technology to continuously monitor your patients with lichen planus and to then designate whether there is true malignant transformation. All of these tools put together, we believe, will enable us better assessment of the clinical lesion, better assessment of the histopathological, cytological, and cellular features in real time, and obviously, ultimately, better original data that will help us to build a case around the true malignant potential of lichen planus. In this particular instance, you can see an inflammatory infiltrate on CLE on the far right with early malignancy on a background of lichenoid inflammation. So the features are quite similar to those noted on standard H&E and require the same interpretation. From that first study, we were able to show the very high sensitivity and specificity of this approach. All of the cancer cases were diagnosed correctly in real time using CLE, and the positive and negative predictive values were very high, and the level of accuracy for the presence of dysplasia or worse was very high at 89%. So we believe this particular approach is useful for monitoring lichen planus cases instead of continuously taking biopsies, invasive biopsies from patients. And of course, I'm sure there will be other developments that will come over time. So in conclusion, I'd like to summarize with this particular slide. Hopefully, we've shown that lichen planus is a combined clinical and histopathological diagnosis, and both are required to render that diagnosis. That lichen planus should exclude the presence of dysplasia for accurate reporting, but also for all of the ongoing research required in this domain. That there should be a dichotomy of diagnoses between lichen planus and dysplasia, and that should be really prioritized as far as classification systems. That lichenoid dysplasia is not a distinct histopathological entity, and we really should move away from using this term completely. This further complicates the argument around the malignant transformation potential of lichen planus. I'm very supportive of synoptic reporting for dysplastic cases, and I believe they are useful in cases where there's a discrepancy between lichen planus and the presence of dysplasia. It can be used for both cases. And there are potential suggested sign outs that we might want to explore further instead of rendering a diagnosis of lichenoid dysplasia. For example, oral epithelial dysplasia with or without an inflammatory infiltrate. And we might go on to designate what the inflammatory infiltrate may be. If we're not sure and we're making histopathological assessments alone, we might sign out a case as oral lichen planus in the correct clinical context. Of course, making sure that the clinician is still inputting from their clinical point of view whether the patient truly suffers from lichen planus based on the clinical features. Are the features bilateral and symmetrical? Hopefully, I've shown some evidence of molecular profiling supporting the lack of evidence for malignant transformation of lichen planus. And again, a lot more work needs to be done in this space. And then finally, highlighting some optical technologies that may be able to be used as a non-invasive diagnostic or a non-invasive surveillance method for assessing lichen planus and monitoring the natural history of lichen planus in an attempt to resolve some of the issues around the discrepancy of its malignant potential. So thank you. With all of that, I'd like to conclude. Happy to take any of your questions. If you have any questions we can't answer today, by all means, reach out through email, and I'll try my very best to answer. Thank you once again for your time today, and again for the kind invitation to present here. Thank you.
Thank you. That was wonderful. And I must say, really, really detailed and exhaustive work. We have
Thank
questions.
you. Thank you very much. Happy to take them.
Yes. Uh, They have been coming in for some time now. So let me start with this. Okay. Dr. Vares is asking, can you confirm the role of biopsy in the diagnosis of OLP? Do we need to take a biopsy of a clinically recognizable bilateral radicular region, which is highly suggestive of lichen planus?
Yes, thank you very much for the question. Based on the American Academy criteria, the simple answer is yes, you must take a biopsy, even if the lesions are highly suggestive of lichen planus, even if the lesions are bilateral and reticular. For one simple reason is that the designation and that diagnosis is both based on clinical grounds and histopathological grounds. And if you don't have the biopsy, you can't make the histopathological, you can't meet that histopathological assessment. From a research point of view, if we're arguing about the malignant potential of lichen planus, if you did not take a biopsy which showed the pure absence of dysplasia on that initial biopsy, and that patient went on to demonstrate any evidence of transformation, then you can't designate that case as lichen planus with malignant potential. So it is important, I think, based on clinical grounds and for research purposes. Thank you.
Yes, very good. And we have a question from Dr. Geronimo, and it is in three parts. So it's just a hi, excellent lecture as usual, Dr. Farag. Leukoplakia is considered an OLPM, and it is accepted that it can have dysplasia. Next, if a given lesion can become malignant, it is to be expected to have dysplasia at some point. Thus, why do you think dysplasia should be excluded from the diagnosis of oral lichen planus since it can be transformed?
Yes, that's a very good question. Thank you very much. So this is where I don't think any amount of time is going to be able to answer this question with great certainty. But this is where we need to be very specific on also understanding the role of dysplasia in oral lichen planus. And I did not discuss any, in oral leukoplakia, and I did not discuss any of this in relation to leukoplakia. However, if you look at leukoplakic cases that do not demonstrate dysplasia on biopsy, and you undertake molecular assessment of those lesions, you do find a subclassification of those lesions that demonstrate what we call genomic dysplastic features. So, what I'm trying to say is there are early changes that we are seeing at molecular level that, if those lesions were followed, would demonstrate cellular changes that we could identify under histopathology that we would call dysplasia. And therefore, the separation of leukoplakia with and without dysplasia may be arbitrary, based only on our ability to detect those changes using currently known or usable tests, such as microscopy, such as histopathology. If we're looking at leukoplakia in a molecular sense, the continuum is actually quite large. Very early molecular changes, medium or mid-term molecular changes, late molecular changes that then result in cellular changes that are then observed by us. So I understand the issue of basically separating out dysplasia in the context of lichen planus and why one would exclude that from the diagnosis, but in very similar sort of format, the etiology, pathogenesis, and natural history of an inflammatory condition such as lichen planus is completely distinct from that of leukoplakia. There is a problem if we start to bunch all of these lesions together as oral potential and malignant disorders. And when we look at leukoplakia, we do make designations and differences between leukoplakia with dysplasia and leukoplakia without dysplasia. However, on histopathological assessment, we always call out dysplasia as the malignant driver of transformation, right? So, in that case, if that particular disease entity in its own right, dysplasia, not seen in the initial part of an inflammatory condition, is the driver of malignant transformation, why would we not exclude then dysplasia from a diagnosis of lichen planus? So I don't believe the two are similar. The disease process is quite different. I think the molecular data that I showed towards the end in looking at the dysplastic features from cases that had lichen planus to start off with and cases that had leukoplakia to start off with showcases that the true driver is the dysplasia. It is not the lichenoid inflammatory infiltrate which designates the lesion as lichen planus. Hopefully that explains that, but I'm sure that we could argue about that for many more months to come.
That's a part of the whole process, yes. Right. So we have a couple of questions from Professor Hill. So the first one is: has the feature of interface mucositis be evaluated in these different epithelial lesions with lichenoid inflammation?
Right. So I'm not sure if I understand the question correctly. I'm assuming the differences between each of the lichenoid lesions, whether they be lichen planus, lichenoid mucositis, lichenoid lesions in their own right, lichenoid dysplasia. We haven't undertaken any of that assessment itself, other than to say that the inflammatory infiltrate has been well, we've attempted to pull apart the inflammatory infiltrate, not necessarily the transmigration of the inflammatory cells through the epithelium itself. And based on that assessment, whether you're looking at features observed under standard microscopy, whether you're looking at AI algorithms for designating lichen planus versus non-lichen planus lichenoid lesions, or looking at immunohistochemistry and any other profiling using either molecular markers like we have in some of our papers, there is a distinct difference between the infiltrate. Whether it's purely lymphocytic, whether it's a mixture of, or a lymphoplasmacytic or a lymphohistiocytic infiltrate, that can be used as a designating feature. Beyond that, I'm not sure that there's any particular work on the interface itself. Hopefully that answers that question.
Yes, I think it does. We will have to ask Professor Hiller. He will tell us,
I'm
I'm
sure
sure,
they'll
in
let
the
me know.
visit. Yes, quite. Yes. And the second question is, has anybody analyzed the changing expression of CK13 and CK17 in these various lichenoid epithelial disorders?
Okay. Not to my knowledge, although I won't mention any names currently. I do know of one group looking at CK17 in not only these lichenoid epithelial disorders, but also in the context of straight epithelial dysplasia based on grading in the context of epithelial dysplasia, but also on other verrucous changes. Specifically in relation to lichenoid pathology, I'm not sure.
Thank you.
And third question.
Now we have moved on to
Thank you.
Professor Nasser. Hello, Nasser. After a long time, you're back. Anyways, so the superb discussion. I still see pitfalls depending on how we classified lesions from the get go histologically. There should be also clear basic histodifferentiation correlation. Yes, I think that's what you were
Yes,
saying.
yes, absolutely agree. Which is quite difficult. And what I've noticed in my practice, at least, is the movement away from reporting dysplastic cases or any cases with dysplastic features, including lichen planus, including lichenoid lesions, to synoptic reporting. And that's why I put up that synoptic report earlier. And the reason why I think the synoptic reporting focuses us, forces us to look at each of the criteria every single time. We become otherwise very easily biased in moving away from the features that are commonly cited and familiar to us. The synoptic reporting forces us to look at each of those 16 architectural features and each of the 12 cytological features for every single case that we look at. And I think if you go through a move to synoptic reporting, you might find a similar outcome. I've observed that in my reporting. I've also used that in cases where we're trying to get inter-observer agreement between pathologists or oral pathologists doing other research with other dysplastic or lichenoid pathologies. And every time we come back to synoptic reporting, we're more likely to actually achieve consensus. And if we're more likely to achieve consensus, we know that more than likely the diagnosis is more accurate. So that's one attempt to try to move us to what you're saying. Thank
Yes,
you.
at least going forward. It's a good checklist, I guess. Yes,
Exactly.
it makes a difference. Yes. Then we have from Dr. Hafid. Thanks, Dr. Farah, for the great lecture. Should we take a biopsy for each clinically appeared OLP with even a completely benign bilateral appearance? I think you already answered that.
The simple answer is yes.
Yes. Okay, then we have everyone saying very nice lecture. And okay, Dr. Hafet has added saying that because some clinicians diagnose OLP without a biopsy and describe medications for it without biopsy. But well, I guess the correct way
And
is with the biopsy.
exactly. And I would say those clinicians potentially are playing with fire without knowing categorically that they're dealing with lichen planus based on the criteria. Obviously, other than the fact that if it's purely reticular, there should be no prescription of medication unless the patient has atrophic or ulcerative or erosive pathology and has symptoms. But if you want to avoid medical legal grounds, um, and until you've probably gone through that based on medical legal grounds, at least in Australia, the US, the UK, Canada, you will be found wanting without a biopsy. So I would urge you, for your own sake, to take the biopsy.
Good point. Right. We have a question from Dr. Mari. I hope I'm saying that right. Thank you for the excellent lecture. How long should the follow up time be to study the OSCC risk among OLP, OLL patients, since that also affects the results?
Yes, very good question. Um, I mean, a lot of the transformation around dysplasia itself is probably a guide. So, if we believe that there was any evidence of these dysplastic features in our lichen planus, and they're potentially transforming within 4 to 5 years, then it would make sense that we're following our patients for 4 to 5 years before we clear them as non-transformed. I think the jury is still out, to be totally honest, around the length of time in the context of lichen planus itself, because if we're diagnosing it correctly and we believe that exclusion of dysplasia is a criteria, then potentially we could be reviewing them for many, many more years before we would be able to satisfactorily say there was no transformation. I would like to make the distinction here in your question around oral lichenoid lesions. Oral lichenoid lesions implies that you're not dealing with lichen planus, which means you are not dealing with a bilateral symmetrical clinical condition. So if you have a unilateral lichenoid lesion, say on the buccal mucosa or the tongue, and you don't see an equivalent on the contralateral side, that lesion should be approached with more suspicion for the presence of dysplasia in its outright context. There, the importance of biopsy is highlighted even further, and the importance of the selection of the biopsy site is more important. This is where non invasive technologies that maybe guide you to where you biopsy or may give you an assessment, a whole assessment of the lesion is more important. Following up on those lesions will probably take a lesser amount of time. Our own experience is about 4 to 5 years. And that's truly because those lesions mostly harbor dysplasia on initial biopsy. So I don't think you can group the oral lichen planus with oral lichenoid lesions. I believe they are two distinct entities. Hopefully that answers your question.
I think you have very well highlighted that the two are very distinct and should begin being separated rather than constantly clubbed together.
Correct.
So we have more of a comment. Dr. Sonali Shah saying similarity may be attributable to similar inflammatory pathway and their resultant impact even at the genetic end.
Yes,
Yes.
that's
And
that's potentially true. I'm not sure which lesions you're comparing there in the question, but I'm assuming the lichen planus and lichenoid dysplasia that I highlighted.
a very good point by Professor Hiller. That is, what we are missing is data on tobacco and other potentially carcinogens by patients with OLP reported with malignant change.
Yes, there is some of that data available in the systematic reviews and the studies that looked at the meta analyses around that. Obviously, patients with smoking history had higher malignant transformation rates. Patients with alcohol consumption history had higher malignant transformation rates. Um, this is potentially where the smoking and alcohol consumption histories of those patients are confounders to the natural history of lichen planus. Now, we could say that smoking and alcohol are confounders to the natural history of the development of dysplasia in a very philosophical sense. But this is where the separation of those etiological factors in the context of dysplasia of normal oral mucosa, and then added to that is what some people believe oral lichen planus is a confounder to normal oral mucosa because it's an inflammatory process. So, do we truly have here multiple disease processes occurring at the same time? We have the natural genetic susceptibility of a patient for lichen planus, believing that it may be an immune mediated or a true autoimmune condition. No one's proven that it's autoimmune, but let's assume that it is. And then we have a separate set of etiological factors, smoking and alcohol, which are known to induce driver mutations in normal epithelial cells to induce carcinogenesis. Why can't it be that both are occurring in a patient with lichen planus at the same time? Yes, the data that we have available to us in the literature does not allow us to tease these things apart with great certainty, which adds to the complexity of the overwhelming evidence from the systematic reviews and meta-analyses around the malignant transformation potential of lichen planus, especially when patients are smokers plus or minus alcohol consumers. I think if you start to tease that information apart, you might find, in actual fact, lichen planus is even less of a problem in the context of malignant transformation. The second part to that is we know that tissue that is already affected by other disease processes, so I'm going to call out, for example, dysplasia. If you continue, dysplastic epithelium, if you continue to insult that dysplastic epithelium with smoking, with alcohol, with other carcinogens, you will continue to drive molecular changes towards malignancy. Um, who's not to say that that exactly is a process that occurs in lichen planus? So I think until we can tease out the smoking and alcohol consumption histories in patients with lichen planus versus lichen planus cases with no smoking, no alcohol consumption, then make assessments around the malignant transformation potential, we won't know. But you're right, we don't have that data available to us in any meaningful sense. Thank you.
True. Hopefully, going forward, the recording will be more
That's right. We
effective.
need better recording. Exactly.
Yes. Okay. Pondant, Dr. Pondant. Excellent lecture. Recent research paper on microenvironment of OLP and OED concludes that OLP and OED has a significant correlation with dysplasia, but whereas the present results are opposite. Whether your presented results are opposite.
Yes, so one, I don't know what recent paper you're alluding to, but if it's the inflammatory microenvironment alone, um, from your question, it says that the OLP and OAD has significant correlation with dysplasia. I'm assuming that dysplasia is the disease entity, not necessarily the OED as far as the dysplastic features on whether that be on architecture or on cytology. What we're suggesting is that if you're looking at the inflammatory infiltrate itself, and you're looking at the gene expression of the whole lesion. We did not undertake microenvironment sub classification of, in our transcriptomic and exomic studies. We can't find any significant differences between the groups of lichen planus that so-called underwent transformation and lichen planus that were monitored for a similar amount of time and did not undergo malignant transformation. We're not making global comparisons, I guess, or statements around the similarities or differences between lichen planus as an entity and dysplasia as an entity. That's the first part to that question. And the second part is I'm not sure how this particular paper designated lichen planus. I'd want you to go back and look at that and see if dysplasia was an exclusion criteria on their assessment of lichen planus. I don't know which paper you're reporting. Thank
Yes.
you.
Yeah, that would make a lot of difference. Okay. Professor Vinay Hazare says he agrees with the molecular profile and great work. Thanks.
Thank you very much.
And
Much
I
more
think
needs to be done.
yes. And the last one, I think, from Dr. Varis is it's an interesting observation that there is no gene that is a marker of malignancy of OLP, especially with the first taken samples.
Yes, thank you for that. And we did think that potentially there would be some profile, some biomarker set, some set of genes that might give us a hint as to what pathway these first biopsy patients would be on. But to our surprise, we could not elicit that. Obviously, we'll be analyzing the data further, but at this stage, we can't seem to designate that from the first biopsy. That's why we've looked at the subsequent biopsies to help us to understand, is there something occurring more in the timeline of development that's still to be determined. Thank you.
Right, thank you. We have some more great lecture and compliments, but let's just wrap up with what about you? You have given us a lot of detail. What about
Yeah.
you summarize it in three takeaway points?
Three takeaway points. I think from the questions, I should summarize the first one by saying oral lichen planus is a distinct clinical and histopathological entity that requires both clinical assessment and histopathological biopsy for a definitive diagnosis. So, unless you have both, I don't think you've got a diagnosis. Secondly, um, any lesion that does not meet those criteria of lichen planus, which includes, in my humble opinion, the exclusion of any dysplasia, is not lichen planus. And we should stop putting all of these various lichenoid lesions into the same pot. They are distinct lesions, conditions, disorders that have distinct etiologies, distinct pathogenesis, distinct tendencies for malignant transformation, and distinct treatment regimes. And we should not treat them the same. And then finally, I'd say a coupling of both further molecular assessment, hopefully with some new imaging platforms, should help us to transform the way that we take care of our patients in the future. There's still a lot more work that needs to be done, but I think as a collective, we need to do better, and we all need to do our bit as far as taking care of our patients, but also contributing to research in this area. Thank you.
Very well put. Very well put. And truly amazing work. I'm so happy you spent so much of your time and did great work with the lecture and with all the questions you took.
You're
I think
welcome.
it really made a difference. Thank you so
You're
much.
welcome. No problem at all. Happy to
Most.
contribute.
Thank you. So let me share your little certificate. And thank you so much. It's a very little token of appreciation from Oral Pathology 360.
Thank you very much. I appreciate it.
Thank you. And I do hope you will be back soon with another lecture for us sometime.
Happy to do so.
Thank you so much. So now we just have one more thing before we say bye, and that is to share the upcoming event, which is this week on the 27th. We have our journal club with authors, and this time the um, topic is aging and oral squamous cell carcinoma development by Dr. Sevan Nicklander, and as an expert, we have Professor Hunter. It should be very interesting. You get a chance, of course, to ask the author and the expert whatever questions you have. Do join us for that. With that, let me say bye to everybody. Thank you for being with us. And yes, for all your comments. And thank you, Professor Farah. Thank you.
Thank you very
Bye.
much. Bye bye. Have a good night.
Bye. Bye. Have a good evening.